Hey, good evening, everyone. Ben Brafman, the Academy for Addiction Professionals. This evening, we're going to do a webinar on trauma and addiction. It's a very valuable topic, and I'm going to go through the following subject matter within this. Number one is defining trauma. So we're going to get into that. Number two is the prevalence and impact of trauma. Number three is understanding addiction. Number four is the relationship between trauma and addiction. And then a little bit later, we're going to get into some treatment models and trauma informed care. So we'll go through all of that. There's a lot to cover in a short period of time. Afterward, we'll have some Q&A, and I hope that you all have some questions, and I hope that I can answer them effectively, and we'll go from there. Again, I'm Ben Brafman. I'm the manager of the Academy for Addiction Professionals. You can find the Academy on addictionacademy.com. You can also find me, benbrafman.com, and take a look and see what we're offering and what we can do for you. So without further ado, we're going to get into trauma. So the first question, the first question here is, well, what is trauma? When I think of the word trauma, I think of a car accident. I think of something that's awful, screeching noises, loud noises, maybe blood everywhere. People screaming and yelling, just some sort of just terrible experience that people go through. Sometimes you'll think about, and I might be dating myself a little bit with some of the people out there, but sometimes you'll think about movies like the movie Jaws, and how Jaws forever changed the way that we viewed swimming in the ocean, or maybe the way that we viewed movies. We still hear the music playing, and that could be a form of trauma, an event. Something that's life-altering, life-changing. So trauma, where does it come from? Well, it comes from the Greek word meaning wound. Wound. W-O-U-N-D, wound. When is something traumatic? When our capacity to cope is overwhelmed or is inadequate. So whatever it is that we have going on in our brain, whatever experiences we have, regardless of the age or gender that we can't believe what we are seeing and what we are experiencing. And that is something traumatic. So that's a very important distinction, in that what's traumatic to one person is not traumatic to somebody else. So when you are counseling someone, or you're dealing with someone that is going through trauma, you're going to want to identify that for them. What is it that they're able to handle? I call it their constitution. And that's something that I'm going to bring back later on as a theme, is what is a person's constitution? In other words, what is actually happening to you versus what you're experiencing within that event. And then, is it more than an incident, or is it the interpretation and perception of that experience as well? And of course, that's also at the heart of this, is that your perception is reality. So again, we have to be very careful therapeutically when we are dealing with trauma victims, or people that are calling themselves trauma victims. Again, their experience is not your experience, and it's not the next patient's experience. So that's something that we're going to, we're going to really take some time with. SAMHSA, the Substance Abuse and Mental Health Services Administration, describes individual trauma as resulting from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has a lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. And that's a very important distinction too, because if you think about the mental, physical, social, emotional, spiritual well-being, if one of those elements that makes you up as a human being is out of whack, has perhaps suffered a traumatic event, then you are going to be a trauma victim, and you may be cycling through that for a very, very long period of time. So we're going to get into all of that. And of course, if you add the part of addiction is going to complicate things. So one of the questions that I want you to ask yourself is, how does trauma impact a person? So here's one way. The world is neither safe nor predictable anymore. What was once the rules are no longer the rules. So that's one way that it impacts a person. And that's a critical distinction. Number two, it disrupts this ability to accurately read others, rendering the mechanism of threat and detection defective. In other words, what they're actually experiencing, they may not think that they're experiencing. They don't trust themselves. They become either too sensitive, or they're not able to detect danger. They may attract bad people or bad actors into their life. The trauma survivor may become either less able to detect danger or more likely to misperceive danger where there is none. So in other words, they're almost hypersensitive to their environment and the people around them. And of course, if you think about this a little bit, how does trauma impact person? And I just rattled off three very key points, and we're getting into the characteristics of trust and of empathy and compassion and what a person experiences. So we're going to go over that as well. The DSM-5, which should be your Bible, and many of you probably have labeled your DSM-5 if you're like me, so you can flip right to it instead of going through it hundreds of pages at a time. So in a nutshell, the DSM-5 definition of post-traumatic stress disorder, right? Trauma. So here's a couple things that you need to know. Exposure to an actual or threatened death, right? So exposure to death, exposure to actual or threatened serious injury. So a car accident, maybe you didn't get hurt, but you almost did. A sexual violation. Women experience this a lot when, they say the word no and they are sexually assaulted. Direct experiencing things, or you could actually witness things. The witness part is critical because a lot of times people will grow up in traumatic families and they will report that it was a traumatic family, and their parents don't have any idea what they're talking about. And basically they witnessed a lot of yelling and screaming and hitting and violence and all other kinds of stuff. So what else does the DSM-5 say about post-traumatic stress disorder? Well, it's an intrusion of symptoms, right? An intrusion means that these are unwelcomed feelings, thoughts, possibly behaviors that a person experiences they don't want in their lives, but it's intrusive. It's flooding their thoughts and their brains. Avoidance. They want to avoid anything associated with trauma, which of course speaks to relationships. It could speak to environments. It could speak to family members. A person can really start to shut down and avoid life. Cognitions and mood. They just have negative reactions to things where the situation didn't call for that. They may have arousal difficulties or reactivity of things. It's basically a retardation of some of the normal functions that we go through. The other thing that the DSM-5 says about PTSD is that the duration of symptoms are longer than a month. Very, very important distinction. a lot of times people with trauma, people with PTSD, they'll have sadness, they'll have some depression, they'll be upset, but it's really not trauma. But if it's recurring and it's lingering and it's longer than 30 days or a month, as the DSM-5 says, then you might be talking about some post-traumatic stress disorder. And so the DSM-5 makes that distinction. And then, of course, functional impairment due to these disturbances. And functional impairment is, well, you can't function, you can't work, you can't have relationships, you have, you don't have friends, you isolate, all of that. So that's the DSM-5 in a nutshell. The prevalence of trauma. So these are some statistics that I want to share with all of you. Statistics, I just want to caution you that these are accurate statistics, but nonetheless, they could vary depending on where you are and what kind of population that you're treating. But trauma impacts about 60% of men and 50% for women. 80 to 90% of us have had a traumatic experience of some sort. That's a pretty high number. About 10 to 20% develop post-traumatic stress disorder. Very critical distinction that I'm making here. And I have a PowerPoint, which I actually can get to everybody. And I do have references to cite. I just want to make sure everybody understands that. I'm not just making up statistics and numbers here. But of a traumatic, of an event, about 20%, 10 to 20% actually develop PTSD, which again, you could have symptoms, but it doesn't mean that you actually are diagnosed with PTSD. It's about 10 to 20%. And then long-term prevalence of PTSD is hovers around the 7 to 9%. So again, if 80 to 90% of people are experiencing a traumatic event, about 7 to 9% of those people, that's developing into real trauma, lifelong trauma. So just a little bit more of statistics that I want to share with you that has to do with age. So according to the SAMHSA guidelines, according to some of the numbers that they have, this is data also from the National Comorbidity Survey replication. Excuse me. So as far as females go, ages 18 to 29, there's about 4% chance of post-traumatic stress disorder being diagnosed. In men, 30 to 44, about 3.5%. Ages 45 to 59, interestingly, men and women was about 5%. Just a couple of more statistics for everybody to have. And now we get into addiction. So we have trauma. We know that it affects men and women fairly equally, which probably is a little surprise to some people. But I want to share with you now some things about addiction that go along with trauma. And I'm just going to pause for a moment. To me, addiction, it is in the foundation of addiction is in anxiety, and a lot of addiction is born from a traumatic event that turns into PTSD, and of course turns into the disease of addiction. Why do we use drugs and alcohol? Well, we use drugs and alcohol to change our mood, right? Because we're uncomfortable with something or someone. A lot of times we don't know the root cause of it, and so we self-medicate. And so here are some statistics that go along with that. In the United States, there's about 41 million marijuana users. roughly about 15% of the population. And they associate that marijuana use and trauma can be a deadly combination. Psychotherapeutic drugs, we're talking about prescriptions like opioids, sedatives, tranquilizers, stimulants. 18 million people in the United States are using those type of prescriptions abusively, I might add. Cocaine is 2.2% at 5.9 million. Hallucinogenics, 1.9%. Inhalants is less than 1% at about 1 million. Methamphetamine is about 1 million. And heroin is at 0.3. That's according to SAMHSA and some of the statistics that that they have for this. My belief is if you suffer from addiction, you've had trauma in your life. And so, according to DSM-5, there are two groups of substance-related disorders as it relates to addiction. One is substance use disorders, and the other one is substance-induced disorders. So the criteria for substance use disorders: taking a substance in larger amounts or for longer than you're meant to. So you know how it says as prescribed, and you're taking, instead of taking one Percocet every 4 hours, you're taking 6 every hour. That might be a problem. You might have a substance use disorder. Wanting to cut down or stop using the substance but not managing to, that's a big indicator. Trying to control it, and yet it's controlling you. Spending a lot of time getting, using, or recovering from the use of substance, you have a substance use disorder. Craving and urges to use the substance, you also have a substance use disorder. So the DSM-5 is pretty clear about how it looks at addiction. There's a few more criteria that I thought I would share with you. Another criteria of the DSM-5 is not managing to do what one should at work or at home or at school because of substance use. Continuing to use despite problems in relationships. Giving up important social and occupational and recreational activities because of substance use. Using substances again and again, even when it puts a person in danger. Now, think about that one as it relates to trauma. So your inhibitions are lowered. You put yourself in a dangerous situation when you're using drugs, especially using drugs that you shouldn't be using or you're using excessively. Continuing to use even when the person knows they have a physical or psychological problem. Oftentimes, I can't help it, or they'll say something like, I know what I need to do. Needing more of the substance to get the effect they want, which of course is called tolerance. Your tolerance level and your withdrawal level are the two key indicators if you have the disease of addiction. Development of withdrawals, which can be relieved by taking more substances. Again, that's part of tolerance, and withdrawal is part of the two main foundations of addiction. So a couple of more stats for you, and I apologize if I'm boring you with a bunch of stats here this evening, but it is important. This is from SAMHSA. This is pretty recent. This is 2018, 2019. It's not that long ago. Mental and substance use disorders in America. Okay, so among those with a substance use disorder, 3 in 8, 36.4% struggle with illicit drug use. 3 in 4, 75% struggle with, you guessed it, alcohol use. Alcohol has always been around. And then 1 in 9, which is 11.5%, struggled with illicit drugs and alcohol. SAMHSA likes to make the distinction. I'm here to tell you that it's all under one umbrella, alcohol and drugs and everything else. We distinguish it because it's good for statistics. Among those with a mental illness, 1 in 4, 24%, had a serious mental illness. So 24% of people that use drugs in the United States have a mental illness. That's an incredible number. 7.6%, 18.7 million people aged 18 and older had a substance use disorder. 18.7 million. 18.9%, or 46.6 million people aged 18 or older had a mental illness. 3.4%, 8.5 million, 18 plus, had both substance use disorder and a mental illness. So we are dealing with an epidemic. I know that we're dealing with COVID and we're dealing with that pandemic, but this pandemic isn't going away anytime soon, and it is impacting and killing our youth. So, comorbidity, trauma, and addiction. 80% of those with PTSD meet criteria for at least one psychiatric disorder. 16% of them have one additional disorder. So, a lot of times when somebody has PTSD, there's a good chance they're going to have also another diagnosis. 17% have two or other diagnoses. So now you've got PTSD, depression, schizophrenia, bipolar disorder, drug use. Nearly 50% have three or more disorders. So if you have trauma, you're more than likely to have a substance use disorder and another emotional disorder, depression, anxiety, what have you. The most common disorder is substance use disorder, followed by anxiety and depression. Men in alcohol abuse or dependency, 52%. Men in drug abuse or dependency, 35%. Women in alcohol abuse dependency, 28%. Women in drug abuse or dependency, 27%. So the men score higher on that. And if you recall, statistically, there's about a 10% higher indicator for men having to deal with PTSD than women. Men fall out at about 60%, where women are about 50%. So now we get to the heart of everything. I've established what trauma is, right? We're otherwise known as PTSD. And I've established what addiction is, and now you've got some statistics. The relationship between trauma and addiction, well, it's very complex. At times it's unclear and it's evolving. What do we know? And what do we know about self-medication? The hypothesis of self-medication that indicates that there's been some trauma. Addiction creates vulnerability for the re-traumatization. You're living it over and over again. Similar brain regions are implicated in both trauma and addiction. Stress and trauma create a vulnerability towards maladaptive coping. So what do we know? We know that the use of drugs does not help your trauma. But here's the problem. And that seems like a very logical thing to say and common sense that that people have. The fact of the matter is that when you're dealing with the disease of addiction, it's very seductive. So when you start feeling differently and you don't have to think about the trauma that you experience, whatever it is, that's how the cycle begins, because you feel better. At least seemingly you feel better, and you feel like you can do things that you didn't do before, and that you're not thinking about things like you were before. And of course, that lasts for a period of time. That doesn't last for a very long period of time. And then the trauma that you never dealt with comes back in full force, and it's a vicious cycle. So what do we do here? The work of what's the work of trauma treatment, of recovery and healing? The challenge of recovery is to reestablish ownership of your body and your mind and of yourself. That's the challenge. That's that constitution that I mentioned earlier, that you have things that happen to you, but how do you deal with them? What is your makeup? This means feeling free to know what you know and to feel what you feel without becoming overwhelmed enraged, ashamed, or collapsed. Putting it in perspective, basically. For most people, this involves finding a way to become calm and focused. Learning to maintain that calm in response to images, thoughts, sounds, or physical sensations that remind you of the past, so they won't impact you as much. Finding a way to be fully alive in the present and engaged with the people around you. Not having to keep secrets from yourself, including secrets about the ways that you have managed to survive, and manage to survive, and allowing the opportunities for validation. In other words, when somebody gives you a compliment, you actually take it. Reducing harm to oneself and one's environment and to health. Obviously, if you're not suicidal or homicidal when you were before, you're doing better. So the inherent paradoxes of trauma treatment. So one of the immediate paradoxes is, let's revisit the trauma without overloading the patient, which could turn into re-traumatizing somebody. But if it's done in a safe environment over a longer period of time, success rate, the outcomes are much better. Reciprocity through social contact and connectedness. So in other words, getting used to the idea of going out socially and working your way up to that. For example, perhaps you had a traumatic event at a family reunion. So instead of going to the family reunion, you start to act out what would it be like to be at the family reunion? What would a good outcome be? And you work through that with your group or with a therapist. Feeling safe needs a visit to an unsafe and disturbing past in mind, body, and spirit. It's really, really beneficial to revisit the past in a safe environment with a professional. Here's the challenge, though, of trauma and some substance use disorders. We've got to incorporate and understand the relationship between the two, the role of the addictive behavior in managing the trauma, its triggers, and various manifestations. For example, ask yourself the question, I know I'm in trouble with my recovery when, right? When would that be? What does your beast look like? What does your trauma look like? What does it feel like? Draw it out, write it out, talk it out. Because once you make it real, you can then deal with it. The origins of both in the traumatic past. What are the origins of it? What really happened? The reality that recovering from either requires recovering from both. Abstinence and withdrawal. We must deal with one if we're going to deal with the other. Vulnerability to relapse, confrontational approaches, and then programmatic challenges and integrations of treatment. Confrontational approaches can work for some, but for others, it simply may not work. I don't know about you, but I don't know if anybody here would like to be yelled at. So I don't know about confrontational approaches, but it does work with some. Here's some PTSD approaches that you guys are familiar with. And if you're not familiar with it, I'm going to share them with you and certainly look into them. Of course, the tried and true one, my favorite, cognitive behavioral approach, prolonged exposure approach, which is very effective. Something called SIT, which is stress inoculation training. There's trauma recovery and empowerment. There's skills training in effective and interpersonal regulation. That's basically teaching you to regulate your thoughts and your feelings. There's EMDR, eye movement desensitization reprocessing, which has become very, very popular. And then somatic experiences. So those are some of the therapeutic models that have been very effective with trauma. Not everything works, and not everything is for everybody. But I wanted to share some guiding principles to all of them that'll be very effective when you're dealing with somebody who's drug addicted, alcohol dependent, and suffering from PTSD. Number one, creating safety. That's a must. The person must feel safe or they're going to relive the traumatic experience. Number two, before any clinician can engage in task-oriented trauma treatments, they have to focus on resolution, and a set of coping skills must be in place. You've got to have some coping skills, an exit strategy, if you will, before anything can really go take a deep dive. Cultivation of recovery, what's called recovery capital social support systems. Basically, are you part of a AA or NA or EA, Emotionals Anonymous? Are you part of a group? Do you have help outside the therapeutic environment? Therapeutic relationships and boundary setting, very, very important. Dealing with ambivalence in addiction treatment, which has to do with what we know as motivational interviewing. How committed is someone to getting this done? A lot of psychoeducational material. Building emotional expertise. So the role of emotional regulation, again, tempering expectations, dealing with low frustration tolerance, lifestyle changes that may come into play, and of course, relapses that may happen. So we've gone through a lot. Here are some of the things that sort of stand out, that individuals such as yourself and other professionals should look into. And that is, what's the screening and assessment process? We talked about that earlier, of a traumatic victim. So you need to know that. What are some treatment activities? We talked about that earlier. What can you actually do? We went through that. Parenting skills. Always good to find out what the latest parenting skills are, what's effective for children, and what isn't. Trauma-specific clinical services, being able to deal with the trauma specifically and not put somebody in a position where they're speaking to a professional that doesn't really know what they're talking about. And of course, understanding crisis intervention, which we have reviewed. So lessons from trauma-informed care. Safety comes first. You must cross-train all the staff. There must be staff peer support. You've got to meditate. Believe it or not, I have it on here. It's unclear which may have come first, but most likely trauma sets the biochemical stage for maladaptive coping, one of which is problematic substance use disorder. So trauma comes first, usually. Trauma and addiction affect trust, building relationships. Okay. And the last thing that I'll say, or one of the last things that I'll say, is that addiction and trauma are really linked together. Addiction of any sort is a trauma. The things that a person does within their addiction is traumatic. And so in order to be successful, you have to separate the two. They do have to be treated separately, and you can't do it in a quick manner. Anyway, I hope you enjoyed the webinar this evening. If you have any questions, I will open up the floor now for any questions.
Okay, number one, how do you get a client to share trauma? What if you know it's there, but they won't discuss it?
So how do you get a client to share trauma, especially as a clinician? You know it's there, but they won't discuss it. So I think that this is a great question, because this happens more often than we'd like to admit. But people with trauma don't want to talk about it. So one of the things that you can do, first of all, is meet a person where they're at and build up trust and empathy with them, so they can get more and more comfortable. And as a result of that, they'll be ready to talk about it when they're ready to talk about it. One of the mistakes that clinicians make is that they see the answer before the client does, and they're going to they're going to jump in, and a lot of times that messes everything up. So that's one thing. The other thing is through storytelling and metaphors. A lot of times a person won't be able to talk about their traumatic experience, but they will be able to relate to stories. And a clinician can tell a story that's relatable to the patient. That takes some creativity, but that type of therapy is extremely powerful. It's non-confrontational, non-threatening, and I've seen tremendous results in it.
Number 2, how do you judge the effectiveness of the trauma-informed care at a facility?
How do you affect the trauma-informed care at a facility? So that's a great question, and I'm going to answer it. I wish I could speak to the crowd, but I think what you're asking is, how do you know a treatment center can do trauma? Can help somebody? And the answer is, you've got to see what their staff is licensed as. Somebody who's just addiction professional probably doesn't have the trauma experience that is needed. Obviously, years of in the field is important. What I would do is I would interview critical staff. I would interview the medical director. I'd interview the clinical director, and even maybe some of the nursing staff, to get a flavor of what the culture is there at the treatment center, and what they do. What do they do for trauma? And if they use some of the things that I talked about tonight, you probably feel a lot better about it. The other thing is, and this is in the social media world, is go to the reviews of the that reviews are, they're not always accurate, but go to them anyway and see, just get a taste of what people are actually saying about that treatment center. Anyway.
Number 3, what are the signs that you are pushing too hard?
Well, one of the signs is that a patient leaves. That's definitely one thing. Another sign is missing appointments. Another sign is that they completely shut down. Another sign is that they relapse. That they're quiet. They change the subject constantly. Those are a lot of signs that you're pushing too hard.
Yeah.
Oh, I had a technical difficulty. We lost the feed to get the Q&As. If you guys could submit your questions in the chat feature, please do that, and I will respond to them ASAP by email. I appreciate everybody's time. I thank you for listening to me, and have a very good evening.